Hi, good afternoon, everybody. My name is Samar Al-Duri, and I'm a consultant gastroenterologist at Medical City Hospital for Military and Security Services in Muscat, Oman. And today it's a great pleasure. I'd like to welcome my good friend, Dr. Andrea Sorge, who's an interventional endoscopist and a gastroenterologist from Milan, Italy. And I had the pleasure of meeting Andrea and working with him during our fellowship in Ghent, Belgium, uh, under the supervision of David Tate. And today, the idea behind that is to talk about like the chronicles of a fellow. We've already done this in a few episodes back with another colleague, and here would like to speak about this fellowship effect, how it affects the skills, judgment, and the cost of this. So, Andrea, thank you so much for joining us.
Thank you very much, Samer, for the kind invitation. It's a great pleasure being here with you and with all the people listening.
All right. So, Andrea, we've both done we've been working for a while, done some sort of fellowship, so we can admit it that it changes you in ways that nobody actually tells you about. Nobody, there's no brochure about it. There's no information about it. So I'm thinking today we're gonna skip the gadgets and the guidelines of how this should be done, but focus on how doing fellowship or a post training post can rewire or change your judgment and how you recover from that as a physician. So what if you would up your fellowship in one sentence, what did you think you were signing up for, and what was the reality?
Well, I think, like as often happens in life, reality was completely different to my expectation. My expectation when I applied for the fellowship was like more focused on technical. Like I wanted to gain expertise in EMR, let's say, advanced EMRs. I was really, really focused on technique. And then during the fellowship and the months, I found out what true competence is, and that's your goal to achieve true competence, not to learn EMR, not to learn ESD, but to learn many, many things like from how to deal with patients with lesions, not to directly with lesions, or how to deal with patients with motility disorders. So focus on the patient first. Then there is the environment. There is the colleague working with you, the nurse. So there are different levels, different layers you need to pay attention to, and you will during a fellowship like the one I had the luck to undergo. You can develop all these items, and by doing so, I think at the end you can gain competence, or at least go towards that competence, know what the direction is. I think you can then start your independent practice, selecting cases,
Mhm.
knowing your limit. So there is a lot going on. It's not about the technique. I would summarize it like as it is. Like I focused more on the technique first, and then I found out there is way more than that.
Hmm. I think this is like this kind of a say invisible upgrade, because I mean when you do a fellowship you put it on your CV and it looks really nice that you have done that, because not everybody does that, but that is that really the biggest change, right? I think biggest change is something that, as you said, an internal kind of transformation of how you behave and how you as a physician and as a human, right?
Yeah, definitely. You're challenged being in an like a different environment with frequently people go abroad doing fellowship, so you have also to deal with that. So non-technical skills, social skills, all of that is so important, and you learn it by working, by making experience. You learn that without that you cannot achieve anything. So there are
Hmm.
different steps. For sure, there is a technical part, and you want to gain competence, and of course, um, like high volume centers are the way to go for that. But there's also non-technical skills, dealing with colleagues and know what to do to achieve the best in all the situations.
Hmm. So you touched upon this competence part that we all chase when we try to pursue this fellowship. But I think it's slippery. I think especially in the beginning. And in real life, I mean, what does competence feel like in the room for you? I mean, when do you sense that someone, maybe even yourself, has crossed that line into unsafe confidence?
Yeah, I think true competence is when you really know what should be what's the right direction, but you know also what can go wrong. So you can anticipate, so be proactive in terms of anticipating and trying to avoid complications when it's possible. But you will make complications if you do an interventional endoscopy for sure. And then you know if the complication happens, how to solve it. That's the critical difference that competence makes. I guess that's just, of course, my opinion. I mean, I don't want to say. I just want to share my experience with those watching, hoping that this is of help. Um, but I think, yeah, when I watched David, like our mentor and our supervisor or tutor, what was impressive and the difference was that he was in total control of the situation, and also if anything went wrong, he knew how to solve it, and he knew how to avoid the complications. So indeed, you need to strive for that, I think. And these are, I think, key elements of true competence, but they are also indeed, he was able, for example, of managing all the team. That's essential. The nurses, the fellows, all those involved need to be engaged, need to be active, need to participate and be stimulated. So I think leadership um, has also a great role in true competence in interventional endoscopy, at least. You need to be a leader of the room. You need
Mm,
to lead also and liaise with the anesthesiologist, but you are in care of the patient. So you need to take care of all the elements to achieve
mm,
the best care for the patient.
mm. Yeah, I was like there's this conversation I was recently with somebody that told me that they had also done a fellowship, and they said that early on they used to confuse familiarity with mastery, like because they had seen so much, like let's say third space endoscopy, so it's so familiar to you, like the steps and how they should be done. So he thought that like I can master this until until they started the fellowship, and I was like, okay, seeing so much is great to know and anticipate, but it takes quite a while to actually master something. So how long did it take you to unlearn that one? Because I think just me and you are maybe similar in a way that we have spent quite a lot of time on virtual learning before doing things with our own hands, right? Did you feel that when you were about to do something like, okay, I can do this? You couldn't?
Yeah, I totally believe like virtual learning nowadays in 2026 is essential, because otherwise have you would require a huge amount of time just to talk, for example, about theory, where you can have all that theory learned up front, and then when you're there with the scope in your hands, and if you're lucky enough to have a competent tutor close by, you can focus on technique and drill down on technique in those occasions. So I think indeed virtual learning is essential. So there are prerequisites for training, in my opinion. Virtual learning and like conscious competence is one of those. Then I think there is for sure, because it's a technical ability indeed at the end, performing procedures. If we focus on interventional endoscopy, for sure there is a true element of natural predisposition and also talent, I think, in dexterity and tip control and all those stuff that at the end make an endoscopist also really good. Like surgeons, like there are surgeons who can perform crazy procedures that others don't. So you need to be lucky with that. But there is also, it's not also only that. There are way other elements, many that they are important. But I think a true competent trainer is able to deconstruct, and we in Ghent, of course, and in Geeks, and like the deconstruction of the procedure was essential, and I think that's a very useful way of learning. So that's the procedure. For example, the ESD, you divide the procedure into different steps. So there is the injection, there is the incision, there is the dissection, there is the closure, and all these steps need to be mastered, but they can be mastered in um, different days, different steps of your learning curve. So you can maybe start focusing on the technique for injection, and then you can start adding the incision when it's easy to do it. Then incision in difficult, for example, in difficult location or difficult situations. Then summicodal dissection and bleeding management. Then defect assessment and clip closure and so on and so forth. So indeed, it's not easy, but at the end, if you join all the dots at the end, I think you need to be patient, but you can really gain competence after a fellowship like that.
Mm-hmm. Um, yeah, this is I fully agree with this, and I think that any kind of post training post training post or a fellowship, I think it does break a few beliefs or preconceived misconceptions that we have. So, and I know I've had some before I started training into more advanced stuff. But in your case, what do you think your biggest uh-oh, or that is that not true? Like, or is this really how this is supposed to be done? Moments. Can you name a few things maybe that can be also familiar for other people listening that like where you think like, well, is this I've learned this all wrong, or this why is this being done that way?
Well, endoscopy as many things in medicine. Like there are also way of doing things, and I have to be honest. I learned basically I learned endoscopy by having David as a mentor before he was actually my mentor, because I really believe in indeed. And Muscat Endoscopy Academy, I think, is one of the platforms where you can do that. You can basically have a lot of knowledge, and you can select also different mentors from virtual learning, or you can read those papers they publish and really know. You can watch procedures online, and you can really know someone's technique, like someone's way of doing some stuff. So I learned by watching geeks and learned endoscopy. I already went to Ghent having their approach. But that's just my experience. Of course, it wasn't like that for all the people. So I was really aligned. I knew what the tutor wanted from me, how he wanted, of course, things done. This is not applicable to all procedures, of course, but for basic stuff, I think the background of what you want to do then in advance. Um, I mean, I can say I paid a lot of time. I spent a lot of time studying and knowing what was expected from me, and I think this was a key element of a successful fellowship, I suppose. But you can, I mean. I didn't have an idea of detailed idea of the steps of advanced procedures because I focused on the basic ones before going there. So I was really solid on the basic things of endoscopy, also simple EMR. And then when I was there, I learned from scratch all the most advanced procedures. So I really didn't have expectations on technical things. I just learned them while I was there by doing them and watch them. But as you said, indeed, watching and doing is a completely different thing, and you can think as someone watching, I don't know, Messi playing. That's easy. That's easy to do that. I can also do that, but then if you have the ball in your foot, that's not the case most of the time. So.
But you said you were like you spent some time studying. So like, did you study guidelines? Did you study like how your mentor was doing things? Did you study how your own reactions to stressful situations? What did you do? Because me personally, I like before, like I do a case that like a planned case, and I do this all even when I'm doing like an emergency, like let's say some bleeder that is an emergency bleeder or something. I was like, my timeout usually consists of first of all, like, just like calming down and thinking about, okay, do I have everything I need in my toolbox? And then I check my staff if they know what we're doing before I check myself usually. And then I look up something that maybe might, show up during this procedure, okay, how to do like, like a certain setting for something, if I need to change the setting of like, let's say, for on the electrosurgical unit or something, something that you can anticipate that may come up that you want to like, that you want to revise it quickly. Because usually studying for me of the actual thing is the last thing that I used to do, and I spent a lot of time on this mental preparation. How do you do it?
Well, I mean, having a checklist, as you said, I think is essential because if you do things with if you have a protocol and you follow it all the time, every time, I think you really avoid mistakes like pilots when they pilot airplanes or in these situations they really have a checklist and they go through and like it is in surgery and endoscopy is way more and more similar to surgery. So we need to apply, I think, some sort of checklist when we do interventional procedures. So first of all, we need, I think, I always discuss this. So I do the timeout with an anesthesiologist I have in the room. So I say, like I introduce myself and be sure they know the names of all the people involved and present in the room and their role. And we go over the cases to be sure they're aligned and they know what the comorbidities are, what we're gonna do. Um, how long a procedure will last, if there are expected complications or things that may go wrong. So this is the first thing. But my checklist is also beforehand. So before being there on that day, I go over the cases scheduled and I think, is this the right, like I doubt myself. Like also what I did maybe 2 or 3 days ago or a week ago, is this the right procedure for the right patient? Do this patient
Mm,
have alternative? Uh, do we have the right environment for that procedure? Do we have the right equipment for that procedure? Am I the right endoscopist? All these things, and if the answer is yes, 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 and then I think you can go on that day and really, I think, minimize the chances of making mistakes.
mm. There's a great thing that you said there, like, are you in the right place? Are you with the right people? And are you the right person? And I mean, this is so much maturity, right? I mean, like as a doctor, I think there's so much maturity in that statement, like because ego can always come into into play, right? It's like, yeah, I can do this. So, but so you personally, how do you draw that line between bold and reckless? How do you decide which case you take, which you delay, and which you just walk away from? Other than like that mental checklist, I mean, is it when you look at the image or the video of the lesion, or like or when you read the history of the patient, or like how do you make what tips that line for you?
Well, I always think like, and what if this patient was my dad, for example? I think you need to consider that, like, for example, if we have a complication, am I able, if I'm alone, to solve it, or do I have background to solve the complication if it happens? But if you feel like it's unsafe to proceed or to schedule a procedure in your department, I think there is no shame or referring it. Actually, I think that referring patients is the way to go. Like for example, I go very practical. Like I'm now in a department where I'm the only one performing this kind of procedures, so I'm slowly starting because I know I'm young. Of course, I have experience and I have training. I spent training, but I'm not a top expert. I can manage everything on my own. And of course, also there is like you need to consider the colleagues cannot support you, for example, or also the nurses are inexperienced, and this is also very important. So I think you need to identify also hub centers or other tertiary centers with more experience than the one you have. And maybe the most complex cases, even if you really have a minor doubt, you cannot finish the procedure on your own, you can refer those patients and maybe ask to go there and watch the procedure with them when they perform it. By doing so, I think you can learn, you can still progress a lot, and you can build up a network, collaboration, maybe also for research purposes. And I think the patients can only benefit from that. So I think it's very important to like put ego on a side and do what's best for patients. I know that's not easy for most people, but other people really refer very easily. And you're the only one who can know where you have to draw the line for yourself. What are you
Mhm.
confident or not? But I think after you finish a fellowship is a critical moment when you have like to prove that you can do the things you did in a protected environment and really um, like high volume centers, and you can replicate those in another situation, maybe uh, with more complexity or with less facilities. So you really need to
Mhm.
be careful, I think, and to select cases at the beginning, go very slowly. And then if you see that things go well, for sure progress and do more complex stuff.
I think it kind of it's in some way it's akin or similar to when when we first graduated med school and like we start our first job and we spend most of our time in A&E working in the emergency department. And we are fresh out of med school. We have learned a lot, but then all of a sudden you start seeing those really sick patients that are have so many comorbidities, and everybody thinks that you should be able to manage this now because you're a doctor, you know. But that's where like you realize, damn, I don't know what to do here because what I was taught in med school was so like such a protected environment, discussed everything with everybody, and like I never had somebody that had all that this list of like 30 different meds that keep them alive. And now all of a sudden I need to know why they have like chest pain, and I think in a way it's quite similar. So but with maturity probably we can let go of that ego and decide, okay, this is not the right thing for me. But does it happen in your case that, or has it happened that you start something and somewhere halfway or during the procedure you think like, okay, it's time to pause or hand over or like just stop, I cannot finish this. Um, has this happened to you? And if this happens to you, what would you say to other people that have been in that situation? Because quite many of us may feel shame when this happens, but we shouldn't. What would you say? What is your experience? What would you say, or what do you do?
Yeah. So no, I want to keep it very practical. So one of the first cases I was asked to perform when I came back from Belgium was a 6 centimeter sessile lesions of the ascending colon. They say you can do an EMR for that, but I thought maybe this is not a good idea. So I thought maybe we can go for ESD and do a very controlled uh, dissection with bleeding management because I was afraid, of course, of very large vessels on that lesion. So I didn't refer it directly, but I tried to resect that lesion. Also, there was a little bit of a concern for deep invasion with these sessile lesions. Optical diagnosis is not always easy to do. So
Yeah.
I started the ESD, but it was like my second ESD in that center. So the nurse didn't know the knife. I was completely alone. It was August. Everybody was on holiday. So many things that were not ideal. So I started, and after the lesion was huge, and after a certain point there were multiple bleedings. Um, I think something like 6 hours passed, and I was, I think, at 50% of the lesion, and I saw something that maybe was compatible to master retracting science, so suspicion for deep invasion. So I stopped. After 6 hours, I stopped. Referred the patient for surgery, not directly. Like I clipped it and then referred the patient to surgery. And at the end, surgery showed deep invasion, deep submucosal invasion. So it was still a T1, but it was deeply invasive. Of course, I think very difficult to say it up front. But this was a case I learned from for sure. I think it was the wrong decision to start it for me as the second ESD I did in my center all alone. And maybe for everybody, because I think that was really an edge case for endoscopic resection. And I think these mistakes are part of your learning curve.
Mm.
You need to avoid them as much as you can, but they are unavoidable, I think. Everybody makes mistakes, but you need to protect patients as much as you can, of course. I really thought I could help that patient with a resection, but maybe I was overconfident. Because also what I was able to do during the fellowship, as I told you, was not applicable directly during the first procedures in the other center. So you need to test the waters with some easy procedures, I think. And then if you prove it that you can do it well, then you can slowly progress. But that's my experience. For example, one case I remember that I learned from.
It's very funny because this reminds me of the of the first case that I did here in my center, where like it was a transverse colon lesion that also felt suspicious, and it ended up being also a T1 tumor with the superficial invasion. Where I started also took about like 3 hours just to get around it. And in the end, like, I just like, my nurses, they were new, and I started getting tired, and anesthesia people, because this has never been done in the hospital before, they didn't
Yeah.
understand what I was doing, despite explaining to them from the beginning what it is that we're doing. That is, this is endoscopic surgery, what we're doing. So it will take the time it takes. So in the end, I ended up doing a hybrid thing where like I snared when I had the whole thing, I snared it, and it was according to like histopathology, it was an R0, but I was not very happy with it, so I still referred the patient for surgery after histopathology, and they ended up like doing a partial colectomy on this patient. So I mean, you learn from these things. You do, and it humbles you. I think it's a good way of thinking about it. So, um, But I mean with this mileage as you go, I mean some of these complications they start feeling like bad luck. So is there some complication now that you can see coming earlier? Something that you used to call unexpected, and now you just like, of course this will happen.
Yeah, yeah. So I have two clear examples in my mind. Like one is perforation after EMR or ESD, for example, like delayed perforation, where you complete the procedure, you think everything is all right, and then 2 days after, one day after, the patient ends up with a perforation. So this never happened, as far as I saw with the cases performed both in Ghent and in my center now, in Milan and here in Padova, where I am now, because indeed we tried to anticipate them paying a meticulous attention to the defect. I think this is really something you should keep in mind, like inspect the defect is key, using maybe also water near focus or some sort of magnification, because you really can see muscle damage. And if you see it or you see something that maybe not reassuring, then you can decide to target it with a clip. And I really believe this anticipates a lot of complications of this kind. And another example where delayed complications can really be avoided is a poem, for example, and I'm specifically referring to perforation, like mucosal injury and then delayed foot thickness perforation after poem. Indeed, it's the same principle. Like after you finish it, especially if you're a trainee, you really need to inspect the mucosa very carefully. And if you have even the slight suspect that the mucosa may be damaged, then you can clip it, and this really avoids delayed complications and perforation.
For people listening, Andrea, sorry for interrupting here. For people listening who may not know what you exactly are talking about, perforation where exactly at the mucosa? You mean along the tunnel on the mucosal side, or like, up on top of the where you on top where you made the incision?
No, I mean that one of the most frightening complications and the most devastating complications of POEM can be perforation. And the perforation, when it occurs, is full thickness because you don't have the muscle anymore. And if the mucosa is not there anymore, you have a hole from the esophagus through the mediastinum. And mediastinitis is very bad. So when you perform POEM, you need to pay attention to the mucosa, not to damage it when you dig into the submucosa. And sometimes these delayed perforations are just mucosal damages that are not recognized. So if you're meticulous, really, and you really pay attention to the mucosa, to the aspect of the mucosa at the end of the poem, you can identify some, if mucosal damage occurs, you can identify it early on. And if you clip it, you can just prevent a devastating delayed complication. So I think in delayed in interventional endoscopy, like in surgery, like in fine surgery, you really need to be meticulous and maybe paranoid about your complications, but you need to bear in mind what those complications are. Try to avoid them as much as you can. But these are
Hmm.
two clear examples, I think, of things I didn't know. Like I didn't know. I thought it was maybe perforation after EMR was something unpredictable or unavoidable, or and that's not the case, I think. Yeah, so that's my experience. I don't know if you have a different examples of things you wanna.
Uh, yeah, no, I mean, I fully agree with you. I mean, the parts where like, similar things where sometimes you hear, I mean, during my training is before coming to get even like early on, it's like, when you hear like, oh, well, sometimes say shit happens, like, you do a procedure where there's an, you do a polypectomy, and like, these things happen in that percentage of cases, and you shouldn't like lose some night's sleep over it. But the cases that for example, I've had a case where I resected, like, an adenoma with EMR. That was like many years ago, and it was like seemed to be like just a regular tubular adenoma, low-grade dysplasia. There was some focal high grade, but it was fully resected, and patient was gonna come back for their, surveillance 3 years later, according to, to the guidelines. Because after, the first one after 6 months was fine, and they come back after for the 3 year mark, and when they came back for a 3 year mark, they had a big cancer growing just out of that exact place. And then, when I went back with my eyes 3 years later, and looked at all the images that I had taken the first time when I did the first resection, it was so clear to me, like, of course, this should not have been done this way. But you cannot know this, but just right off the bat. And I think these are the things that you learn to as the more you learn, the more experience you become, the better you become at reading the lesion in front of you. And
Hmm.
Dr. Mohammed Noor in Leeds, when I was there for my ESGE fellowship, he said he used to say something really cool. He used to say, like, the polyp speaks to us in a certain language, and us who do interventional endoscopy have learned that language, so we can actually understand what it's saying, and based on that, we decide the right approach. And this so I think this is something that comes only, like, with that experience and humility, that you're always gonna have to, like, really pay attention, like, use your best scope, spend time, use all the modalities that you have, like, from white light to MBI to RDI and whatnot, and use your water jet, and do not accept bad, like, less than optimal bowel prep, or and try to avoid any expected issues by just, like, put a clip if you have to put a clip. I mean, there's so much chatter about, like, whether, I mean, and this, right? I mean, like, there's so much chatter about, like, okay, whether to clip a big lesion in the right colon or left colon. Like, there's no, you don't have to clip a big lesion in the left colon, but maybe you should do it in the right colon. Now they say maybe you don't have to clip it in the right colon, but there's so many studies that come on this. But, like, I don't know, what do you think? But my personal feeling is that if I feel that this polyp, this defect may cause an issue, I'll just put some clips there, and call it a day. I don't know. What do you do? Do you follow these guidelines, like, strictly, or do you always improvise as you go? What is your approach?
No, I mean, I try always to be scientific in what I do, and to follow evidence as much as I can, and also guidelines. But you don't have, I think, to be blind and to, like, blindly read guidelines and apply things that are written there. Also, because if you read it more carefully, sometimes they are just maybe weak recommendation, low level of evidence, and many people change their practice based on that.
Mm.
I don't know whether that's right or wrong. I think clinical judgment is always prompt everything else. So that needs to be put first. So if you think that based on your judgment on the patient and the situation, maybe the patient lives on, I don't know, on a remote island and wherever, and maybe a delayed bleeding would, or a delayed perforation might be catastrophic, or the patient lives alone. So all these things, I think, need to be considered, and then you need to judge it, especially for gray areas. You know, those topics where the evidence is inconsistent. Maybe you have a study favoring clipping and another study showing no benefit of clipping. Then I think in first, if you can provide more evidence, that would be great. But second, when you have the patient in front of you, then I think you need to do what's best based also on your experience. Like, what's your experience in your center? with you treating those patients, because most of the studies, maybe they are trials in a super controlled environment in top level expert centers, and those data are difficult to replicate in real world. So this is not to say that we should clip everything, but just that we need to be critic in what we do and to always scrutinize what we are doing, to achieve the best patient outcome. That's my approach.
Yeah. Mm. Do you usually ask people around you what they think, even if they are not as they're not on the scope, they are not as competent as you, or they don't like. Do you tell them like just their eyes, what their eyes is seeing? Like, what do you
That's
think about
great. That's great. Like I will quote, as you did, another great endoscopist, who is Professor Bergman from Amsterdam, because I did an observership when I was still a resident, and there was a difficult situation, and he asked me, and then he said, he kept on saying also over the days, like, when you face a difficult situation, you need to ask someone else. And if you don't have anybody, even the least experienced endoscopist or colleague can help you. Um, so you need to be humble and ask for help. And this was something he did and was done in Amsterdam very frequently. Like, there is a difficult situation. Can you please call that guy, that colleague, a friend, and ask for an opinion? Because indeed, I do believe, even if you're the expert, let's say, and you're dealing with people like trainees or residents or students, whatever, I think
it?
that very good idea may come from different mindsets, and it can only be beneficial if you ask for help. And this is something I've seen applied in different situations. Like, what do you think? Should we do that? Yes or no? Let's do a poll, and then of course you decide, because you're the responsible for the patient. But I think this
Yeah.
can be is a very nice approach.
Mm.
Also, I mean, shows humility, and I think that's also a key element for
I think
success.
also it's a sign of leadership too. Like when you do this,
Yeah,
you're like kind of, I mean, you're asking everybody for their opinion, but everybody in there, they know kind of deep down that you're going to end up making the decision. You're going to do whatever it is that you want to do. So it's a good sign of humility and leadership, I think. So it's a really good way of like making everybody feel involved in what's happening, because especially in these lengthy procedures when like especially if we're not as I mean we're not like as I mean I remember David, he used to be able to control everything, but he can also talk with people about other things at the same time while he's doing it, but he's so eyes sharp and focused on what he's doing. I cannot do that. I'm working unless I'm just doing a diagnostic thing, then I can teach. But if I'm doing something so interventional and like I'm in like dug into the submucosa, I don't want any chatter in the room. So it's nice, like always, this is a way to zoom out and like make everybody else feel involved in what's happening. So I think that is really great. Um, so the last question here for you, Andre, I've taken a lot of your time here. Um, was it all worth it?
definitely yes.
Yeah, okay. So you would recommend people to do that, or which source of people would you recommend something like that to if they
Uh,
have the opportunity?
Well, I mean, saying I recommend it to everybody, no, I don't, because I think everything starts from knowing yourself, who you are, what do you want to achieve, and then how can you achieve it. I do believe that doing a fellowship, especially if it's abroad, really gives you something, a lot in terms of experience, like being out of your comfort zone, another country, another mindset. You have so much to gain. And I think also, apart from that, dedicated time to learning interventional endoscopy, I think is is essential. There are many ways of learning. Like I know if you talk to the people, like to the top experts, maybe they're 50, in their 50s now, and they learn basically, some of them went to Japan, for example, but most of them learn just by doing it on their own. Of course, that's a steeper curve, maybe, and less safe for the patient. Maybe nowadays, I think there are good training programs you can apply for, and I do encourage people to do so. But I think you can start as I did with observerships. So you can maybe identify some centers you like, and if you have the opportunity to do that, maybe you have funding, or you can apply for fundings from the ESG, from the UEG. They have programs for that. For example, to go and watch is the first step. Then you may think, maybe I like it. Maybe I like interventional, or maybe I would like to be in this center. And then you can undergo a fellowship. But this, of course, has a cost. Is a huge investment of money. For me, it was, for example, staying far from my family, investing in everything I had for 2 years for learning. But I was really motivated to do so. And of course, it wasn't always easy. There were up and downs in my mood about that. But at the end of the day, it's something it changed my life, and I know also other people with the same experience. So I think it's a very motivating, it's a burst of also of energy and motivation, like to do your best and grow. And I think that's always good if you want to do this kind of career.
Hmm. Yeah, fantastic. I fully agree with you. I mean, like as you said, like start with something small, see whether it's for you, because maybe it's not for you. Maybe it's like, it's like maybe you'll end up hating it. Right? I mean, and that's fine. And that's fine too, especially nowadays in medicine. There's so much you can do. And then if you decide to go into it, it definitely has a toll for like from the cost, lack of sleep, your sanity, family bandwidth, and then all of that. But in the end, I think definitely it is. I fully agree with you. It's definitely worth time and the investment and the amount of personal development also as a human being, not just as a physician. I think like when you go abroad and you and away from home with people that are different language, different cultures, different everything, you actually become a more nuanced, open-minded person who actually understands where people are coming from and why they think the way they think. And I think in this day and age, in this world where everybody's so polarized and everybody's trying to put people in boxes, I think it's a great thing to actually get out of your comfort zone and go see something else, and so that you really end up seeing that we're all pretty much alike as humans. We might feel differently about different things, but we're so similar, and you end up really becoming a much richer person intellectually, culturally, maybe not economically, but hopefully doing the fellowship can solve that afterwards.
Yeah,
Uh,
indeed, because you need to also to seek fun in what you do. I mean, it cannot be just focused on achieving the goal, but you need to enjoy it while you do it. And I mean, these kind of experiences often lead to true friendships, and they're long lasting because you share so much during those days struggling, but you support each other. You also, this is a great, of course, learning point, that you cannot go anywhere alone, and you need a team, you need a network, and these are indeed great opportunities. But you can also do it. You don't have to go abroad. Maybe if you don't have money or the time to do that, you can also indeed visit some centers, some hub centers, tertiary centers close to you. Like there are many ways to learn in 2026. I cannot believe somebody can be like stopped from learning. I'm too naive by thinking it, but indeed there are many ways to learn, and I think you need just to take also time to select what's best for you.
Mm,
Sometimes you don't have to, maybe somebody to advise, and I was it was the case for me. Like I was alone, and I like people in my department they didn't know advanced endoscopy, so they didn't even know where to go to learn. So it's not always easy, but indeed, um, there are many resources you can also take advantage from.
mm. Yeah, it's getting much easier for sure, for sure. Great, Andrea. This was fantastic, great discussion, grounded and straight to the point. You're an honest dude, and that's why I really wanted to speak to you about this. Thank you so much for taking the time, and hopefully we'll do another webinar in the future where we line up a few cases and just chat about them, like so that we go into nitty-gritty details about what it is that we do, on our everyday practice.
That would be great. Thank you very much, Sumer, for the kind invitation.
Thank you.
Thank you for those watching.
Thank you so much. Have a great day. See you
Thank you,
soon.
you too. Bye bye.
Bye-bye. Bye-bye.